Welcome to Pediatric Case Review, Musculoskeletal Series. Today's lecture is a comprehensive case-based clinical review of Duchenne muscular dystrophy, one of the most important and common progressive neuromuscular disorders in pediatric practice. This lecture contains 16 clinical case questions covering pathophysiology, genetics, clinical presentation, examination findings, diagnostic workup, complications, and treatment strategies. Let us begin. Case Study 1. A 4-year-old boy is brought by his mother due to frequent falls and clumsiness noticed over the past year. She reports he has always been a late walker, taking his first steps at 20 months. He struggles to climb stairs and cannot rise from the floor without rolling to his side and pushing up with both hands. On examination, waddling gait, bilateral calf enlargement, and proximal lower limb weakness. No pain reported. No family history is initially available. What is the most likely diagnosis? Option A, spinal muscular atrophy. Option B, cerebral palsy. Option C, Duchenne muscular dystrophy. Option D, congenital myopathy. The correct answer is Option C, Duchenne muscular dystrophy. This boy's presentation is classic for Duchenne muscular dystrophy: proximal muscle weakness, waddling gait, and the inability to rise from the floor without support, known as Gower's sign. The child uses his hands to climb up his own legs when rising, which reflects proximal lower limb weakness. The bilateral calf enlargement is calf pseudohypertrophy caused by fatty and fibrous tissue infiltration replacing muscle, not true muscle mass. Spinal muscular atrophy presents earlier with absent reflexes and hypotonia. Cerebral palsy shows a spastic pattern with perinatal history and is non-progressive. Congenital myopathy is variable, often present at birth, with usually normal creatine kinase levels. Case Study 2. An 8-year-old boy with a known history of progressive muscle weakness presents with increasing fatigue during school activities. He reports needing to rest after walking short distances and has recently developed a mild forward trunk lean when standing. His serum creatine kinase is markedly elevated at 5,000 units per liter. What is the most likely cause of his current symptoms? Option A, anemia. Option B, respiratory insufficiency. Option C, cardiomyopathy. Option D, neurogenic scoliosis. The correct answer is Option B, respiratory insufficiency. Progressive respiratory muscle weakness reduces diaphragmatic and intercostal muscle function, leading to declining vital capacity. Early symptoms include daytime fatigue, morning headaches, poor concentration, and disturbed sleep, often before overt breathlessness becomes apparent. Pulmonary function testing, especially forced vital capacity monitoring, is essential for tracking decline and timing ventilatory support. A critical clinical pearl: respiratory failure is the leading cause of mortality in Duchenne muscular dystrophy. Early non-invasive positive pressure ventilation initiation dramatically improves survival and quality of life. Anemia has no significant hypoxic or muscular basis in this context. Cardiomyopathy causes dyspnea, but not the fatigue-dominant picture described here. Neurogenic scoliosis is a complication, not the cause of exertional fatigue. Case Study 3. A 6-year-old boy is brought in by his mother due to concerns about speech delay and learning difficulties. She also reports that he frequently falls and has been walking on his toes since he began walking. On physical examination, he has a positive Gower's sign and bilateral calf enlargement. He was born at full term with no perinatal complications. What is the most appropriate initial diagnostic test? Option A, brain magnetic resonance imaging. Option B, electromyography. Option C, urine organic acids. Option D, serum creatine kinase. The correct answer is Option D, serum creatine kinase. Creatine kinase is elevated 10 to 20 times above normal in Duchenne muscular dystrophy. Sarcolemmal instability allows creatine kinase to leak from damaged muscle fibers into the bloodstream, making it the earliest and most sensitive biochemical marker available. Creatine kinase levels can exceed 10,000 units per liter in early childhood, even before clinical symptoms become obvious. It is the initial screening test of choice because it is non-invasive, rapid, and cost-effective before genetic testing. Brain magnetic resonance imaging and electromyography are not first-line tests because they do not reflect muscle enzyme leakage. Urine organic acids test for metabolic disorders, not neuromuscular disease. An important note: creatine kinase levels may normalize in late-stage Duchenne muscular dystrophy as muscle mass is lost, so clinical context is always essential. Case Study 4. A 10-year-old boy with a known diagnosis of Duchenne muscular dystrophy presents with worsening fatigue and shortness of breath during school activities. He reports needing frequent rest after walking short distances. He denies chest pain or palpitations. On examination, Heart rate is 98 beats per minute, respiratory rate is 22, and oxygen saturation is 96% on room air. His electrocardiogram reveals tall R waves in leads V1 through V6 and deep Q waves in leads 1, AVL, V5, and V6. What is the most likely underlying cardiac abnormality in this patient? Option A, dilated cardiomyopathy. Option B, right ventricular hypertrophy. Option C, pericarditis. Option D, left bundle branch block. The correct answer is option A, dilated cardiomyopathy. Cardiac involvement is universal in Duchenne muscular dystrophy. Nearly all patients develop cardiomyopathy by late adolescence. Absent dystrophin disrupts the dystrophin glycoprotein complex in myocardial cells, leading to progressive fibrosis and left ventricular dilation. The electrocardiogram findings in Duchenne muscular dystrophy are characteristic. Tall R waves in lead V1 and right precordial leads, and deep Q waves in leads 1, AVL, V5, and V6, reflecting posterobasal fibrosis, which is a hallmark pattern. Echocardiographic findings include left ventricular dilation, reduced ejection fraction below 55%, and wall motion abnormalities in posterobasal segments. An important clinical note: symptoms may be absent early, so cardiac screening must begin at age 6 regardless of symptoms. Annual echocardiogram is mandatory in all Duchenne muscular dystrophy patients from age 6 onward. Case Study 5. A 7-year-old boy with a known diagnosis of Duchenne muscular dystrophy is brought in for a routine follow-up. His parents report that he has been walking on his toes and tends to fall sideways when walking. On observation, he has a wide-based waddling gait with an exaggerated anterior pelvic tilt and prominent lumbar lordosis. When asked to stand on one leg, he immediately loses balance. His gluteal muscles appear significantly wasted bilaterally. Which of the following best describes this patient's gait pattern? Option A, steppage gait. Option B, Trendelenburg gait. Option C, ataxic gait. Option D, spastic gait. The correct answer is option B, Trendelenburg gait. Trendelenburg gait results from weakness of the gluteus medius and minimus muscles. When weight is placed on the affected limb, the contralateral pelvis drops and the body tilts to compensate. In Duchenne muscular dystrophy, bilateral gluteal weakness causes an exaggerated side-to-side waddling appearance. Patients also exhibit anterior pelvic tilt and compensatory lumbar lordosis to maintain balance. The key examination finding is that the pelvis drops on the non-weight-bearing side during single-leg stance. This is distinct from steppage gait, which is caused by foot dorsiflexor weakness with high knee lift and foot slap. Ataxic gait is caused by cerebellar dysfunction and shows a wide base with unsteadiness. Spastic gait results from upper motor neuron lesions and shows scissoring with stiffness. Case Study 6. A 9-year-old boy with Duchenne muscular dystrophy presents with joint limitations affecting mobility. On physical examination, ankle dorsiflexion is limited to 5 degrees, knee extension has full range maintained, hip flexion contracture is present, and overall mobility is increasingly compromised. Which intervention is most appropriate to prevent progression? Option A, surgical release immediately. Option B, immobilization in a cast. Option C, daily stretching exercises. Option D, non-steroidal anti-inflammatory drugs for inflammation. The correct answer is option C, daily stretching exercises. Passive stretching and night splints are the first-line approach to prevent and delay contracture progression in Duchenne muscular dystrophy. Contractures develop due to progressive muscle imbalance and fibrotic shortening of affected muscle groups. Ankle-foot orthotics worn at night maintain dorsiflexion and prevent fixed deformities by keeping the joint in a corrected position overnight. Daily passive stretching focuses on hamstrings, heel cords, and hip flexors. Surgical release is reserved only for severe, symptomatic contractures unresponsive to conservative care. Non-steroidal anti-inflammatory drugs and immobilization in casts are not appropriate and may worsen outcomes. The key principle: conservative management always precedes surgical intervention in Duchenne muscular dystrophy contracture care. Case Study 7. A 5-year-old boy with a known history of progressive proximal muscle weakness is brought in for a routine evaluation. During the examination, the physician asks the child to raise both arms overhead. The parents report that this has become increasingly difficult over the past year. On examination, bilateral prominence of the medial scapular borders is noted when the child elevates his arms. There is no pain, no sensory deficit, and deep tendon reflexes are preserved. Which muscle group is primarily responsible for this finding? Option A, latissimus dorsi. Option B, deltoid. Option C, pectoralis major. Option D, trapezius and serratus anterior. The correct answer is option D, trapezius and serratus anterior. Scapular winging results from weakness of the trapezius and serratus anterior muscles. The serratus anterior holds the scapula flat against the thoracic wall. When weakened, the medial border of the scapula protrudes, and this is the hallmark of winging. The trapezius elevates and rotates the scapula during arm abduction. Its weakness compounds scapular instability during overhead movements. In Duchenne muscular dystrophy, proximal girdle muscles are affected early and symmetrically. Scapular winging becomes prominent when the child raises arms overhead or performs a push-up maneuver. The latissimus dorsi adducts and extends the arm and is not the primary scapular stabilizer. The pectoralis major abducts the arm at the shoulder but does not stabilize the scapula. The deltoid adducts and internally rotates the arm, and scapular winging is not its dysfunction. Case Study 8. A 12-year-old boy with a known history of progressive proximal muscle weakness presents for neurological evaluation. History: progressive difficulty walking over the past 3 years, no pain, no sensory complaints. Examination findings: deep tendon reflexes preserved at knees and ankles, no fasciculations observed, no sensory deficits, proximal muscle weakness greater in lower limbs than upper limbs, and calf pseudohypertrophy present bilaterally. Investigation: serum creatine kinase markedly elevated. Which of the following conditions can be ruled out based on these findings? Option A, spinal muscular atrophy. Option B, Charcot-Marie-Tooth disease. Option C, amyotrophic lateral sclerosis. Option D, multiple sclerosis. The correct answer is option A, spinal muscular atrophy. Duchenne muscular dystrophy features preserved or brisk deep tendon reflexes due to intact upper motor neurons and primary muscle pathology. There are no fasciculations because muscle fiber architecture is preserved at the neural level. Spinal muscular atrophy is ruled out by the presence of normal reflexes and absence of tongue fasciculations. The key principle to remember: Duchenne muscular dystrophy is a primary myopathy, while spinal muscular atrophy is a motor neuron disease. These are fundamentally different mechanisms. In Duchenne muscular dystrophy, reflexes are normal or brisk, fasciculations are absent, calf pseudohypertrophy is present, creatine kinase is markedly elevated, and the condition follows X-linked recessive inheritance. In spinal muscular atrophy, reflexes are absent or diminished, fasciculations are present, creatine kinase is normal, and the mutation is in the SMN1 gene with autosomal recessive inheritance. Case Study 9. A 3-year-old boy is brought to clinic after his maternal uncle was recently diagnosed with a neuromuscular disorder. His serum creatine kinase is markedly elevated at 8,500 units per liter. Genetic testing is performed and reveals a deletion in exon 45 of the DMD gene. Which of the following best explains the absence of functional dystrophin protein in this patient? Option A, in-frame deletion preserving the reading frame. Option B, frame shift mutation leading to premature stop codon. Option C, missense mutation altering protein folding. Option D, promoter mutation reducing transcription. The correct answer is option B, frameshift mutation leading to premature stop codon. Exon 45 deletion disrupts the messenger RNA reading frame, creating a frameshift. A premature stop codon is introduced downstream, halting translation early. The resulting truncated protein is non-functional and rapidly degraded. Without dystrophin, the dystrophin glycoprotein complex fails to assemble at the sarcolemma, leading to sarcolemmal instability and repeated cycles of muscle necrosis. Fat and fibrous tissue replace lost muscle tissue over time. An important comparison: in Becker muscular dystrophy, in-frame deletions preserve partial dystrophin function, resulting in a shorter but partially functional dystrophin protein, producing a milder phenotype with later onset. This is the key molecular distinction between Duchenne and Becker muscular dystrophy. Case Study 10. In Duchenne muscular dystrophy, the absence of dystrophin disrupts the dystrophin glycoprotein complex, leading to sarcolemmal instability and membrane permeability changes. The loss of this critical structural protein triggers a cascade of cellular dysfunction that drives progressive fiber degeneration. Which of the following is a direct consequence of membrane instability? Option A, increased adenosine triphosphate production. Option B, reduced glycolysis. Option C, enhanced calcium influx. Option D, decreased oxidative phosphorylation. The correct answer is option C, enhanced calcium influx. Loss of dystrophin disrupts the dystrophin glycoprotein complex, destabilizing the sarcolemma and increasing its passive permeability to calcium ions. Calcium floods into the myofiber through the unstable membrane. Calpains, which are calcium-dependent proteases, are activated and degrade contractile proteins. Apoptosis is triggered, causing progressive myofiber necrosis. Mitochondrial dysfunction and oxidative stress further accelerate the damage. This creates a chronic cycle of injury and failed regeneration that drives disease progression. Option A is wrong because adenosine triphosphate production is decreased, not increased. Option B is wrong because calcium influx is passive, not actively enhanced glycolysis. Option D is wrong because glycolysis is not the primary affected pathway in this mechanism. Case Study 11. A 5-year-old boy is referred with a 6-month history of frequent falls, toe walking, and difficulty climbing stairs. Examination: positive Gowers sign, bilateral calf pseudohypertrophy, proximal muscle weakness, and waddling gait. Investigations: serum creatine kinase 12,000 units per liter, markedly elevated. Family history: maternal uncle with similar progressive weakness. What is the most appropriate next diagnostic step to confirm the diagnosis in this child? Option A: brain magnetic resonance imaging. Option B: electromyography. Option C: muscle biopsy. Option D: multiplex ligation-dependent probe amplification. The correct answer is Option D: multiplex ligation-dependent probe amplification. Multiplex ligation-dependent probe amplification detects approximately 70% of Duchenne muscular dystrophy mutations, specifically large deletions and duplications in the DMD gene. It is the first-line genetic test because it is cost-effective, rapid, and widely available. If multiplex ligation-dependent probe amplification is negative, the next step is next-generation sequencing, which identifies point mutations and splice site variants. In this case, the creatine kinase of 12,000 units per liter combined with a maternal uncle with similar symptoms strongly suggests an X-linked inheritance pattern and makes immediate genetic testing indicated. Multiplex ligation-dependent probe amplification has approximately 98% sensitivity for Duchenne muscular dystrophy deletions and duplications. Muscle biopsy is reserved when genetic testing is inconclusive or atypical presentation exists. Case Study 12. A 6-year-old boy is referred for evaluation after his parents notice he has been walking on his toes and falling frequently since age 3. He has difficulty climbing stairs and rising from the floor. On examination, bilateral calf enlargement, positive Gowers sign, and proximal muscle weakness in the lower limbs. Initial serum creatine kinase, 18,500 units per liter, markedly elevated. A muscle biopsy is performed. Histology reveals endomysial fibrosis, scattered necrotic and regenerating fibers, and mononuclear inflammatory infiltrates. Immunohistochemistry shows complete absence of dystrophin staining on the sarcolemma. What is the most likely diagnosis? Option A: Duchenne muscular dystrophy. Option B: Becker muscular dystrophy. Option C: limb-girdle muscular dystrophy. Option D: congenital muscular dystrophy. The correct answer is Option A: Duchenne muscular dystrophy. Complete absence of dystrophin staining on immunohistochemistry is diagnostic of Duchenne muscular dystrophy, distinguishing it from Becker muscular dystrophy, where partial staining is present. The histopathological triad in Duchenne muscular dystrophy consists of 3 findings: endomysial fibrosis replacing muscle tissue, scattered necrotic and degenerating fibers, and mononuclear inflammatory cell infiltrates. The key distinction from Becker muscular dystrophy is that Becker shows reduced or patchy dystrophin staining, not absent. Duchenne muscular dystrophy shows 0 staining. Limb-girdle muscular dystrophy has normal dystrophin staining with other proteins affected. Congenital muscular dystrophy has different protein targets, with myrisin deficiency being more common. An important clinical pearl: in any boy with proximal weakness and markedly elevated creatine kinase, proceed directly to genetic testing. Muscle biopsy with immunohistochemistry is confirmatory when genetics are inconclusive or atypical. Case Study 13. A 10-year-old boy has been diagnosed with Duchenne muscular dystrophy for 3 years. He is currently ambulatory and has no cardiac symptoms, no chest pain, no palpitations, and no shortness of breath at rest. His parents ask whether his heart needs to be checked. Which of the following is the most appropriate cardiac screening tool at this stage? Option A: chest X-ray. Option B: echocardiogram. Option C: Holter monitor. Option D: cardiac magnetic resonance imaging. The correct answer is Option B: echocardiogram. Echocardiography is the gold standard for detecting early dilated cardiomyopathy in Duchenne muscular dystrophy, even before symptoms appear. It identifies left ventricular dilation and reduced ejection fraction at a stage when intervention is most effective. Annual echocardiogram should start at age 6. If cardiac symptoms develop earlier, it should be done sooner. Monitoring targets ejection fraction and left ventricular dimensions. Holter monitoring is recommended every 1 to 2 years to screen for arrhythmias. Angiotensin-converting enzyme inhibitors should be initiated when ejection fraction begins to decline. A critical warning: nearly all Duchenne muscular dystrophy patients develop cardiomyopathy by late adolescence. Surveillance must begin early and continue lifelong, regardless of symptoms. Case Study 14. A 7-year-old boy with a confirmed diagnosis of Duchenne muscular dystrophy is referred to the respiratory clinic for baseline assessment. He has no current respiratory complaints. His parents report mild snoring at night and occasional morning fatigue. Neurological exam is unchanged. His physician wishes to initiate regular pulmonary monitoring to detect early respiratory decline. Which of the following is the most sensitive measure for detecting early respiratory muscle weakness in this patient? Option A, peak expiratory flow rate. Option B, total lung capacity. Option C, forced vital capacity. Option D, FEV1 to forced vital capacity ratio. The correct answer is option C, forced vital capacity. Forced vital capacity is the most sensitive marker of respiratory muscle decline in Duchenne muscular dystrophy. It detects early weakness before symptoms appear. Progressive loss of diaphragm and intercostal strength causes forced vital capacity to fall steadily over years, even while the child still appears clinically stable. Serial forced vital capacity monitoring guides the timing of non-invasive positive pressure ventilation. When forced vital capacity drops below 50% predicted, non-invasive positive pressure ventilation discussions should begin. When it drops below 30%, nocturnal non-invasive positive pressure ventilation becomes urgent. Peak expiratory flow rate is effort-dependent and less reliable in young or weak children. Total lung capacity is less sensitive to early respiratory muscle weakness. The FEV1 to forced vital capacity ratio reflects an obstructive pattern, not restrictive, and is not typical of Duchenne muscular dystrophy. Serial forced vital capacity measurements every 6 months are essential for proactive respiratory management. Case Study 15. A 6-year-old boy is recently diagnosed with Duchenne muscular dystrophy. His neurologist recommends starting corticosteroid therapy. His parents ask about the most significant clinical benefit they should expect from early steroid initiation. Which of the following is the most significant benefit of early corticosteroid therapy in Duchenne muscular dystrophy? Option A, prevention of scoliosis. Option B, improved cognitive function. Option C, reduced risk of pneumonia. Option D, delayed loss of ambulation. The correct answer is option D, delayed loss of ambulation. Corticosteroids work in Duchenne muscular dystrophy through several mechanisms. Anti-inflammatory action reduces ongoing myofiber damage and necrosis. Membrane stabilization protects sarcolemmal integrity against mechanical stress. Reduced apoptosis slows programmed muscle cell death. Corticosteroids also preserve pulmonary function by delaying respiratory decline alongside motor preservation, and they delay scoliosis onset by maintaining trunk muscle strength longer. The most significant documented benefit from the FOR-DMD trial evidence is that early initiation at age 4 to 6 years delays loss of ambulation by approximately 2 to 4 years. Without corticosteroids, children typically lose ambulation at age 9 to 10 years. With corticosteroids, this is extended to approximately 12 to 13 years. Prednisone is the standard first-line choice with daily oral dosing. Deflazacort is preferred in some settings due to less weight gain, with both showing equivalent ambulation benefit. Before we conclude, we want to invite you to join the Pediatric Case Review Patreon community. This is your dedicated clinical learning hub where all our lecture videos are organized by system, so you can find every topic easily, anytime, without searching through multiple uploads. All presentation slides from every lecture are also available as downloadable high-quality photos, so you can read and practice offline at your own pace. You can also review every case-based multiple-choice question from all lectures, making it perfect for self-assessment. If you want to join, simply comment below on this post, and we will message you directly with all the subscription details. And that brings us to the conclusion of today's lecture on Duchenne muscular dystrophy. Let us summarize the key takeaways from this lecture. Early recognition of motor delay and pseudohypertrophy is critical for timely diagnosis. Serum creatine kinase and genetic testing using multiplex ligation-dependent probe amplification are the cornerstones of diagnostic workup. Corticosteroids remain the most impactful intervention for delaying disease progression and preserving ambulation. Multidisciplinary care covering cardiac, respiratory, and orthopedic aspects is essential throughout the patient's life, and emerging therapies like exon skipping offer new hope for eligible patients. If you found this lecture valuable, please follow the Pediatric Case Review channel for more in-depth case-based musculoskeletal lectures. New topics are added regularly. Have a question or suggestion? Drop it in the comments. We read every one